Yeah, yeah, true.
All right. Guess what? I'm going to restart my timer, guys. Okay.
Yes,
No
of course,
cheating.
sir. Yes.
So it's at 0 and I'm going to start. And here we go. Okay. So forget everything that I said up till this time and then refocus one more time. We're discussing temporomandibular joint and its disorders and the life of a dentist because we are here attempting to reclaim our patient's bite. Now, are you able to see the new screen?
Yes, sir.
Awesome. So we discussed, friends, that we as dentists are in charge of our patients' jaw joints. Why? Because we are orthopedicians of our temporomandibular joint. If you didn't know this, you now know it. And if you did not think of it like this, believe me, other medical practitioners have not thought of you as a dentist who's going to be able to manage temporomandibular joint disorders. So the onus may be up to us to first go visit our fellow colleagues around us and let them know that, my friend, any patient who comes to you with what you suspect may be a bite or a TM joint issue, feel free to refer them to me and I will try my best to help them. All right, because a lot of these patients may not come to you because they don't understand the problem may lie with the bite or with the jaw joint. And remember, this jaw joint is absolutely essential for us to survive because we have to chew, we have to speak, and we need to swallow. And without our TM joint, we're not going to be able to do this. The temporomandibular joint is stated as one of the most used joints in the human body and also one of the most abused joints. Why? Because a lot of times symptoms do not get associated with in and around the joint. They may be spread over a larger area. Remember, our entire face is supplied by the trigeminal nerve. So problems with respect to TM joint may be referred to a distant area, and a lot of our patients don't realize this. Abuse of the TM joint can be one of the etiologies for a temporomandibular joint disorder getting precipitated. Right? And the TM joint is an extremely complicated structure that I'm going to try to give justice to. It's a beautiful structure, let me tell you that. Why? Because there's so many dynamic movements that are happening. We're not just talking about a static bite. Often when you think of an articulator, it's teeth closed. But no, that's not how the human jaw functions. The human jaw functions by moving dynamically, side to side, forward to back, and up to down. It's a three-dimensional movement. And if I were to look at a cross-section illustration of the TM joint, it's a beautiful, beautiful structure where there's so much that's happening in a small space. There are 12 different structures in one simple sagittal view. And the most beautiful structure in the temporomandibular joint is the TMJ disc, often underrated. I often think of this as the parent of the joint. It's supposed to support the joint. It's supposed to allow the joint to move and mature and function properly until something goes wrong. And remember, the disc is connected. It's a tissue that's very social. It has connections at the front. It has connections at the side. It has connections at the back. So it's very sensitive to any change that happens within or around the temporomandibular joint structure. And remember, each time the joint moves, the disc also undergoes movement. If the joint is rotating, the disc is static. But if the joint is translating, the disc is also moving along with the temporomandibular joint. And this is a beautiful video. It's a cadaveric cross-section video that I want you to first focus on the left side, where you're going to be able to appreciate the movement of the condyle and the disc. It is so smooth. It is so fluid. It's so synchronized that everything seems to make sense. There is no friction that is happening in a normal temporomandibular joint. The pictures that you see on the right side are of a patient of mine where a dynamic MRI was done. And the black portion that you see on top of the joint is the disc. And I want you to appreciate how the condyle translates and the disc is also moving in sync. Remember, they are like two, it's like a glove and a hand. They just fit into each other perfectly well. But we're not here to talk about things that are normal. We're here to talk about pathology. All right. So let me start by saying, Why is there so much confusion with respect to TMD? What is a TMD? We're not 100% sure. There's so much dynamism in literature with respect to temporomandibular joint because everyone thinks of TMD as a different set of symptoms. And the problem started with the inception of someone saying TMDs is something to do with the bite. And this was Costin, if you remember that, in the year of 1934. Do you realize temporomandibular joint disorders are not even 1 century old? And it's only in 1982 where the term temporomandibular joint was finally accepted upon as being the consensus saying, moving forward, we're going to call these TMDs, but we still don't know what a TMD is. Whether it's a muscular problem, whether a joint problem, or whether there's problem related beyond the dentition, beyond the muscles, beyond the joint. And I'm going to try to throw some light on this. Remember, maximum research in temporomandibular joint disorders was happening in the 70s. There's so much with respect to occlusion that was happening there that a lot of dentists said everything in terms of pathology of the TM joint is because of occlusion. If a patient has any symptom related to the TM joint, it's because of occlusion. Period. Nothing else. So what happened is management was only and only directed towards correct the bite. If the bite's the cause, correcting the bite is going to give you symptom relief, which means everything is to do with get the perfect angle class 1 occlusion. So every dentist was only and only attempting to treat the malocclusion. All right, look closely. What happened? Some patients, when the bite was corrected, showed improvement in symptoms. So everyone was like, yes, we're on the right track. The problem, however, we soon realized is some patients did not improve despite bite correction. Uh-oh. What's the problem here? The problem, literature said, is you are not a good dentist. I'm sorry I'm saying this. This is what literature said. You are not a good dentist. You don't understand occlusion. That is why your patients are not improving. The big problem here, friends, is by correcting the occlusion, some patients actually showed symptoms that worsened. And this is where a completely new thought process started. A phase came in, which is currently even present today, where some dentists said problem is only occlusion. Some went on to the extreme end and said, it's not about occlusion at all. No TMDs are because of occlusion. So do you realize there is such a dramatic difference between what people believe in the world? And then there are people like me who believe that yes, occlusion does have a role to play, but it's not solo. There is something else as well that is complicating or worsening the temporomandibular joint disorders. And this is where I discuss very briefly upon how my understanding with respect to etiology of TM joints is. Let me blatantly tell you, there is no single cause that can account for all signs and symptoms of temporomandibular joint disorder, which basically means if you see a patient who has a deep bite or an open bite and comes with TMJ pain, you absolutely cannot say the bite caused the temporomandibular joint disorder. I would disagree very strongly with you. It's not an all or none system at all. Remember, no single etiology can cause all signs and symptoms of temporomandibular joint disorders. Etiology is complex. It is multifactorial. So what are these factors? I'm going to list out from J.P. O'Cason, who beautifully says there are 5 primary etiological factors for any temporomandibular joint disorder. And these are malocclusion. I'm not saying malocclusion is the only cause. I'm not saying it's not a cause. There are other aspects, which means there could be parafunction. There could be prolonged stress. So yes, chronic stress, where an individual cannot find an escape, may act as a etiological factor. Deep pain input, which basically means, let's say I have had a road traffic accident. I have some form of a cervical issue. There may be a nerve entrapment there, which is the source of a temporomandibular joint disorder. And last but not the least is trauma. This could be macro trauma. I fall and I get hurt, and that's the cause. Micro trauma as well, which means I'm frequently clenching, bruxing on an interference, let's say, may also result in etiology. Now, what's important and what's brilliant here is, believe me when I tell you this, you or me 100% have a malocclusion. We all have malocclusions. Because remember, even angle class 1 is called angle class 1 malocclusion. We all have at some point some level of parafunction in our system. We all have had stressful episodes. We may have deep input. We may or may not have had suffered from trauma. The important question here is, do all patients who have malocclusion, parafunction, prolonged stress, deep input or trauma get a TMD? No. If that were the case, my clinic would be flooded with patients, but that's not the case. Not all patients with etiology develop a temporomandibular joint disorder because no two patients are the same. Remember, every patient is different and every individual has different adaptability. It's all the balance between symptoms and an individual's adaptive capacity. Simple example. Imagine someone who has blisters on the finger. This is someone whose etiology is more powerful than ability or adaptability. Having said that, if this individual developed callus, you'd now say that this individual has better adaptive capacity. The same etiology does not cause the pathology because the individual's response is different. Imagine you or me have fever because of the same thing. You and me will not respond to treatment the same way. You or me may not have the same severity of symptoms, and this is epigenetic. There is a genetic makeup, there's hereditary in there, there's environmental in there, there's so many factors that are not constant throughout life. It keeps changing, and that's the problem with temporomandibular joint disorders. It means even if I correct the bite, something else may trigger the temporomandibular joint disorder. Your patient may have a fall and the TMD comes back. Your patient may have stress and the TMD comes back, which means we never cure a TMD patient. We only manage the patient's current etiology and symptoms. Very beautifully put here. Normal function is where a patient is asymptomatic. But you may or may not have one or more of these etiological factors. In the presence of these etiological factors, everything comes down to adaptability. If the individual's adaptability is amazing, this patient's going to go back to normal function. Nothing's going to happen. The etiology is there, but the adaptive capacity is stronger. However, if the adaptive capacity is not that great, the same etiology may precipitate an acute temporomandibular joint disorder. Adaptability is paramount and understanding. Okay. Any and every etiology can be divided as being either a precipitating factor or a perpetuating factor or a predisposing factor. Let's look at the latter first. What is a predisposing factor? It is something that increases the risk. So let's say if you have a deep bite or an open bite, or if you have chronic stress, it's predisposing to you developing a temporomandibular joint disorder. What is a precipitating factor? It could be trauma. मार लगा TMJ issue shuru hua. So that is what initiated the problem. And what is a perpetuating factor? If you have parafunction, if you have deep pain input, if you have stress, that can be perpetuating. Now what's complicating here is one etiology could cause all three, or different etiologies could be causing each of these. So there's so many different permutations and combinations that are happening here that you can never say, this is the cause. This is where I tell you, friends, that if you want to be good at TMJ management, you need to be amazing at this word. This word is actually a jigsaw right now. I'm going to put this into correct perspective. Sadigoncy is nothing but diagnosis. Identify the source. That is key. And remember, the source need not always be malocclusion. Yes, teeth are a source for orofacial pain. But along with that, you may have a muscular source. You may have a joint source. You may have a sinus-related source. There could be a cervical source. There could be a neuropathic source. There could be a neurovascular source. It could be a combination of these. Now, what I'm telling you here is the etiology is complex and complicated. It's not just the occlusion. Please understand that. Occlusion alone does not always cause a temporomandibular joint disorder. There's something called as physiologic malocclusion. It looks horrible, the bite, but it's physiologic to that human individual. That adaptive capacity has taken care and it's no longer pathologic to an individual. If you correct it, you may cause a problem. So be careful. When I say complicated and complex, this is how complex orofacial pain is. On the left side of the red line, friends, is physical axis. On the right side is the psychological or the emotional axis. This is what Bell classifies as orofacial pain. And you know, where does the temporomandibular joint lie? I'm going to highlight this with an orange box, which is on your extreme left of the screen. That is the small domain of temporomandibular joint in the orofacial pain. And imagine if someone comes with a headache, it's not always migraine. If the patient comes in with a temporomandibular joint disorder, it may not always be the actual TM joint problem. Have you ever come across a scenario जहां खाना नहीं खाया तो सिर दर्द हो रहा है? क्या ट्रीट करोगे? सिर दर्द को ट्रीट करोगे कि पेट को ट्रीट करोगे? The stomach is the source. This is the site. If you're treating the site, you are highly mistaken. You are not going to be able to get your treatment correct because your diagnosis of the source went wrong. And a lot of patients start suffering chronically because the diagnosis was incorrect. What could be the symptoms? The symptoms could be in the mouth, but the symptoms often don't stay related to the teeth and the jaw, but they also go into the ear, which is why so many of our patients are actually sitting in an ENT's office. If you know an ENT around you, go talk to them. They're going to be able to refer so many patients because they don't know how to help these people. They're looking for a TMJ specialist. So become one. Get the knowledge, get the acumen, get the skill if you have the desire to help these patients. Of course, you're going to have patients who have headaches that are related to the TM joint. Your patients may complain of pain in and around the eye. It could be orofacial pain that we as dentists can manage. Your patient may have throat symptoms or neck symptoms. I'm sorry, I can't get into the depths of each of these. Remember, this is a Virar fast train. I'm merely touching the surface and letting you know there is more to the bite than just teeth coming and closing together for eating. Don't just keep your blinders on. Open your perspectives because there's a lot more happening. There are a lot more patients who we as dentists can help. All right, remember that. We as healthcare providers form a part that is reducing our patients' suffering. We alone can't treat them. It has to be a team approach. Often I have patients going to a psychologist or a psychiatrist. ENT referrals are very, very, very common. Orthopedics, neurologists, especially when you're talking about neuropathic chronic pains. Remember, all of us together, when we work in cohesion, will be able to help our patients. One size or one approach will not help all patients. We cannot treat all patients. We primarily deal with TMDs. So let me give you an understanding of what a TMD is. It's a disorder of the masticatory muscles and the musculoskeletal system. We call it the stomatognathic system, correct? And there are two types of issues here. Moving forward, we're going to call this TMJDs and OMDs. What's a TMJD? It's an actual disorder of the joint within the fibrous capsule. So it's an intracapsular disorder. And OMD, which is far more common, is an occlusomuscle disorder, which means it's extracapsular. It's not a joint pathology. All of these make up muscular, all of these make up joint. It's confusing, I understand. Having said that, there is a method to the madness. If you understand and begin to visualize what's happening in the joint, you're going to be able to treat a lot of these patients. A very common TMD patient is one who comes with clicking in the joint. Doctor sahab, tak tak awaaz aata hai joint mein se. What is a click? Let's again look at a beautiful video. This is a video that shows a disc that is anteriorly displaced, and each time an individual tries to open, the disc actually snaps back into its position. We call this anterior disc displacement with reduction. It's a loud click, often no pain. If a patient's not getting this treated, this may go into a situation where the click dhire 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 becomes softer, and a point comes when the click is completely gone. No clicking. This is permanent disorder. This is a bigger problem because the disc is completely displaced forward and is not being able to come back to its position at all. What may happen here is the bone may break through the tissues and physically go and contact the bone. So it's condyle contacting the glenoid fossa. This is where arthritic breakdown steps in. Just like how you have knee arthritis, you may also have temporomandibular joint arthritis. Literature talks about a continuum of breakdown. So let me give you a brief understanding of this. It initially, friends, starts with muscular issues. If muscular issues go unnoticed or untreated for a long time, your patient may develop clicking. Clicking may go into catching. What is catching? It sometimes clicks, sometimes does not click. So a lot of patients think I'm improving, but no, it's not improvement, it's further breakdown. This is a critical zone. Up to this point, the entire pathology might be reversible. If the patient comes too late, this is where you tell the patient, Kash, thoda pehle aaye hote. Why? Because this has gone into locking, which goes into osseous breakdown. Some patients, the adaptive capacity improves and this patient may show recortication, which means it's reversal of breakdown. This may or may not happen in every patient. Okay. Now, quickly talking about prevalence. There's so much confusion about this. There's only two things that every article of literature agrees upon. It says peak TMDs are age 20 to 40. So if you have a 60-year-old patient who comes in and there's pain in the TM joint, it may not be a true temporomandibular joint disorder. Please understand that. Females are far more prone to temporomandibular joint disorders than males. One of the articles that I said is 8 female patients, 2 male patients. That's absolutely brutal. That's insane. I feel so sorry for the female gender, especially with respect to prevalence, because they are far more prone, and that age of 20, I'm telling you, is coming down rapidly. I see so many more young kids, college going kids who are coming into me, and we've diagnosed them as having temporomandibular joint disorders. Question arises, how do I diagnose them? 5 methods that I follow. I'm going to quickly run through these. My sincere apologies for doing this. I'm already crossing 20 minutes. We believe in mass screening every patient. So you could probably take a screenshot of this. If your patient says no to all of these, your patient does not have an active temporomandibular joint disorder at this point. Just move on to whatever treatment you are doing. However, if the patient says yes to even one of these, you want to go through a detailed TMJ examination. This is a case history sheet that I have designed, I follow in my practice, and I believe it works well. With the permission of the people at Abbott, in case someone wants it, I'm very happy sharing it with you, but please understand the concept behind it before you start using it. The next thing is dental examination and occlusion. I
request the web stream to kindly mute the audience.
Okay. So occlusal evaluation is not something that I put a lot of focus on because I don't believe occlusion's the sole cause. I look more frequently for range of motion, the amount of movement and the direction of movement. There are certain norms here with respect to comfortable opening, maximum opening, protrusion, right lateral, left lateral, and I measure these with the help of a jaw pitch. It tells me whether the range of movement is normal, is it limited, is it restricted, is it hyper, because a lot of patients today come with hypermobility as well. All right. Then comes direction. You may have seen some patients when they open the jaw, the mandible deviates towards one side and then comes back. The deviation is where there's a click. Some patients may show deviation in one direction, then the other direction, then they come back, which means they have a bilateral problem, that is an anterior disc displacement with reduction. If there is clicking, it's a good sign. I'm not saying it's a good sign for a normal patient, but clicking means the problem has not gone to a point where it's irreversible. You may still be able to bring the disc back. However, once a patient starts moving the jaw in a sideways direction, it's not coming back in. This is now an irreversible pathology because the disc is irreversibly displaced. Of course, you can go ahead and palpate. You palpate certain muscles. Dr. Anurag beautifully said that you want to palpate the masseter and the temporalis. I'm going to add to this saying the sternocleidomastoid and your trapezius muscles, massive culprits in the entire game, right? And you want to palpate those and probably refer your patients to a physiotherapist. You can palpate the joints as well. You're looking for any symptoms and you're looking for any sounds. Again, my apologies. I'm running through this. There's so much that I want to talk about, but I cannot on this platform. Usually when I go through this in my head, I have a tentative diagnosis with me. I know what's the source. Accordingly, I design my treatment plan. Occasionally only do I ask my patient to go for imaging, and the imaging with respect to the TMJ is specifically an MRI. And yes, I know how to read that MRI, and it's no big science. It's very easy to read MRIs. It's just that हमारे दिमाग में रहता है कि oh shit, MRI इतना बड़ा हो, मुझे कैसे समझेगा? It's very easy if you put your mind to it. Please understand, OPGs, TMJ X-rays are non-diagnostic. Most patients have soft tissue pathology. The problem is with the disc. The problem is not with the bone. So please don't give your patients unnecessary X-ray radiation exposure. It's not diagnostic in my world. Quickly coming to management. After having said so much, okay. Now remember, if the etiology is multifactorial, my treatment also should be holistic and multidimensional. I strongly believe in conservative treatment. Over the past 12 years that I've been practicing TM joint management, not one patient has gone through TMJ surgery, not one. With conservative management, we're able to get our patients to a symptom-free level. What am I talking about? I'm talking about the use of self-management strategies, specific pharmacotherapy, physiotherapy, psychotherapy, splint therapy, which is a mainstay of my management protocols, botulinum toxin for specific cases, and last but not the least, a minor chair-side surgical procedure that's called arthrocentesis. When it comes to self-management, I strongly believe that you leave the onus on your patient to help themselves. Simple fundas like you're going to have soft foods. You're not going to chew very hard things. You're not going to chew very chewy things. You're going to bite your food slowly. You're going to chew more. You're going to swallow comfortably. You're going to avoid parafunctions. You're going to avoid tea, caffeine, chocolates, and things like that. Improve your sleep posture. Improve your gait, the way you sit and work. Small little things. I have these charts ready for me that I give my patient as a soft copy or a hard copy. It talks about sleep hygiene. It talks about head, neck, shoulder position, some parafunctional habit breaking designs. All of these things, believe me, have immense value because the patient is healing himself or herself. All right. Pharmacotherapy is something that a lot of people resort to as primary treatment. Please don't do that. It works only for a short time in the acute pain phase. After that, other treatment strategies step in, and those should help your patients. All right. Analgesics work, anti-inflammatories work, muscle relaxants don't. Point blank, don't. Please don't give muscle relaxants. It's not your primary TMD therapy. Anxiolytics for patients who have sleep disorders. Antidepressants, anticonvulsants in low doses for patients who have chronic pain or neuropathic issues. Physiotherapy for any patient where you believe that muscle is the source. And believe me, 8 out of 10 patients who walk into your practice, muscle will be a source. So find a good physiotherapist around you who's going to be able to release those muscles, break those triggers, and allow your patients to heal much, much, much faster. Any patient who's been suffering for more than 3 months is chronic pain. These patients have a lot of anxiety. They may have sleep disturbances. They may be depressive, because they don't know why they are in pain. They look normal. The MRI is normal. The blood reports are normal. And yet they are in pain. So everyone tells them, pain tumhare dimag mein hai. And they land up with psychologists. So you want to look for someone who is good with cognitive behavior therapy. They do wonders. Last but not the least, imagine if a patient has a sprain, you give the patient an orthotic. Similarly, for the temporomandibular joint, we give different types of TMJ splints, and there are multiple types. All right. The last 4 that you see, I don't believe in them. Remember, I started the session by saying soft splints are no good. Soft splints may worsen your patient's TMJ problems. Right? I strongly believe in the use of the first and the second, which is an anterior stop appliance, which is any appliance that fits on the anterior teeth and disoccludes the back teeth. Right? Disoccluding the back teeth has a deprogramming effect on the brain. It kind of calms the muscles down. All right. So the appliance that you see here is an anterior deprogrammer. We call it a Dura Soft with anterior stop. So back teeth should not touch. That's the goal. And it's a hard splint that covers all the teeth. The patient is wearing this only and only at night time. If my diagnosis is a muscular problem, I give this splint. If my diagnosis is this is a true TMJ, which means it's an intracapsular disorder, it's a TMJD, then I want to give my patient a stabilization splint. All right, also called a permissive splint. It's a hard splint, completely flat, small canine extensions. It looks like this in the mouth. The patient is wearing this 24 hours a day. What's the thought process here? 95% of the force is taken up by the splint. Only 5% goes to the joint, so the joint can heal beautifully. It helps in adaptation and it helps in creating what is called as a pseudo disc. If the disc is displaced, the retrodiscal tissue can be painful. The orthotic, when a patient wears over 3 to 6 months, will allow the joint to stabilize. It works brilliantly. If I have a patient who's not improving with any of these and the range of motion is limited, in that case only I do arthrocentesis, which is a lavage of the joint. Right? So you basically clean up the entire joint. Right at the end, we often inject PRF into the joint space. It allows the joint to heal beautifully. Right? And then you go back to your permissive splint therapy, and most often than not, your patients will respond and you will find success in improvement of their symptoms. I know all of this putting together sounds overwhelming, but believe me, it's doable. Please don't think success is I'm going to start the first case and I'm going to be successful all my cases. That is not. That is far from true. Remember, I have had multiple failures where I've tried to understand what went wrong, what could I have done differently, and the success rate only starts improving with time. As I close my session, please remember, we never heal our patients. Patients heal themselves. We merely create an environment for them to heal. Right? We don't cure. We don't treat TMDs. We merely manage TMDs. Remember, a TMD once treated or managed may come back again. So your patient may be a TMD patient for life. I'm sorry, in a short session, this is all I could give you. If you want to learn more from me about this topic, feel free to go on to mikeducation.com. There's a QR code that you can scan. I have an entire course that's there, which is about 30 plus hours, 62 videos in depth. मतलब तुम पागल हो जाओगे सोच समझ के कि क्या कुछ है इसके अंदर. And there's a special promo code for you in case you want to or are keen on registering and learning and widening your horizons about this topic. Big thank you to you guys for signing up, for staying live. And big thank you to Abbott for hosting me and giving me this opportunity. As I come to a close, those are where I am active on social media. Feel free to reach out. I'd like to take as many questions. If I haven't been able to answer them, reach out later. I'd be more than happy to. Dr. Goswami, back to you.
Thank you so much.
Now breathe again.
Thank you so much, sir, for that highly illustrative, informative